how do you think we should look at this problem of growing healthcare costs and the federal budget?
So I'm going to try to divide this into two questions: is how do I view the issue in general, and then this whole question of whether we know whether excess costs are starting to slow down. Let me do the latter one first. I've argued that the estimators who look at this issue should look at the share of the increase in GDP that goes to an increase in healthcare. And for a long time, that's been upward as high as 30%, that of every additional dollar that the nation gains in income, 30 cents on that dollar has been going to healthcare. And very seldom in recent years has it dropped, say, below 20. And in fact, that's one reason why health costs have risen from 2 and 5 and 10% of GDP now towards 20%. And so I don't know that number is actually slowing down enough. And the recent years have been so affected by things like COVID and inflation temporarily above what everybody expected. So maybe the people who are charging the prices for healthcare didn't raise them as fast. So I don't think we really know enough over the last few years, but I think you also have to estimate it the right way. For the bigger budget issue, my view is that healthcare is really the only part of the budget where the power of appropriations has essentially been passed on, not to the executive branch, which is sometimes a congressional complaint. They skipped the executive branch. They passed it on to the public in general. Largely providers who often can either, in some cases, charge what price they want, are to customers who can demand extra health care. I mean, when the commercial on TV says, call your doctor to find out if you want this additional drug as well, they're not saying call your doctor and be sure to come up with enough money to pay for it. It's call your doctor and don't worry, somebody in your insurance world is going to cover that marginal, that new cost. And I should mention also, if you add in everything, including state and local and government employees and tax subsidies, government now contributes about 65 cents on the dollar for healthcare. So, they're not only the flagship, they're the main battleships behind the flagship. And so they're driving a lot of this by the way that their insurance is structured. It's not just the way private insurance is structured. And so I think you can't, we can argue about how you put the system into a budget. I think the simple fact is you just violate every budget principle there is by turning the power of appropriations onto a private sector that can charge other people. I should say not private sector, but private people and private companies.
Well, let's get into, what could you do to bring the more budget discipline to the healthcare sector?
The logic is, and I've also written on this as well, is somebody's got to be able to say no. And the great difficulty in healthcare, it's not just saying no to things that are proven to be worthless. It's saying no to things that might cost $1 to get only 50 cents worth of benefits. And it's not that I don't care about 50 cents more of benefits in healthcare. It's like, I think there's a lot of greater needs in our society, again, for these groups that are being left behind, that I think need to be attention. And by the way, in healthcare, it also means putting more money in preventative care, which does far more good per dollar, gives you far more bang per buck than acute care or chronic care. So somebody has to say no, and it's one of three. I think logically, it's either the individual says no, which is what we do for a lot of market goods. But in the case of healthcare, that's not going to work because it's expensive enough that few people can come up with the dollars. And when they're operating table, they're not going to be able to say no. It's some intermediary, like an insurance company, or so forth, or it's the government. And you've got the latter two, some sense already in Medicare with Medicare Advantage, which says this intermediary gets something like a premium support, and then they've got to keep within that budget. And you've got some of this with the price control side, the traditional Medicare. So basically those two parts of Medicare, to give the simple example, just have to be reinforced, that there is indeed a limit in both cases. Prices can ratchet down to stay within that budget if you're on the traditional Medicare, and in the Medicare Advantage, you go towards setting a premium that's a maximum premium. And I have my favorite of those two, but my main point is you got to put anything you've got into a budget.